thank you for the introduction and the warm welcome here and the ability to share a few vignettes and perhaps some provocative pearls from my near lifelong experience with this disease and the execution of the concept of translational medicine. So greetings from Lake Tahoe. We have had our first snowfall already, but right now we're suffering from the smoke from the California tragedies, which is really very severe. So just to review the history, I was part of this outbreak that occurred in 1984 that involved about 300 patients. And interestingly, I'm still following 82% of those people. And we just finished the 30-year follow-up. So we did a 10-year, a 20-year, and a 30-year, and mostly demographics of what people have died from, what other diseases they've developed, what their medications have changed, what their quality of life is like, and some of those very simple things. To date, myself and my partners have seen 8,000 cases of chronic fatigue syndrome over this 33 years. And so thinking about the art and science of ME/CFS, I just want to highlight some points that I would want to summarize and throw out to the group here. I agree with Beth that subsetting of these patients is really critical. I happen to see a number of patients who classically fit chronic fatigue criteria and turn out to be arsenic poisoning because of the contaminated groundwater in the state of Nevada. And that's a problem that wouldn't necessarily exist in other parts of the country, but is a very big cause of chronic fatigue. And if you withdraw them from the mines or the dirty water, they recover. Big data and precision medicine, it's a concept I'm so excited to hear today from the people who are willing to take this off our hands and do it properly, because there's a huge gold mine to be mined, even if it's just tailings in some cases. The use of statistical methodology and modeling, I think, is a wonderful concept that can be applied to this disease, particularly since we don't know a lot of the critical factors. This, of course, requires a large number of patients and is quite costly, which has prohibited our progress in the past. The microbiome, we've heard a lot about that. I'm fascinated by that. I think it's very interesting. The patients are always ahead of us in this. I have a number of patients who have taken fecal transplants and have had some mixed experiences with it, but I'm very interested in the further research. I think treatment has been abominable for all the reasons that we all know about. I'll just summarize a few of them. The P2P and IOM were great documents, and one of their major criticisms, which I want all of you to think about and help us, is an outcome measure. Every time we presented a study to the FDA, the problem has been, what's your outcome measure? Besides quality of life or improvement in treadmill duration or something like that. I really hope that the FDA and the CDC can help us design the proper studies so that these won't be issues in the future in terms of treatment trials. And of course, a lot of these require large groups of people and hopefully international collaboration. And again, there's obstacles. Certainly, I agree with the IOM and the P2P that research has been fragmented into many, many methodological flaws. Small n's, n's of 5, n's of 10, things like that. And it's very hard to even publish. Large numbers of patients are affected. We should be able to get more research dollars. I completely agree with Ian on that. New technology will certainly help us, and longitudinal studies are in progress. Now, the one big difference, I think, for this disease is that big pharma has not been involved. And I've done a number of drug trials in other fields, and it's always been funded by big pharma. We have tried to get them involved. We went to Genentech with respect to rituximab, and they wouldn't even hear us. Yet a small country of Norway with 5 million people, the government funded a very large, double-blind, placebo-controlled longitudinal study of rituximab. So I think we have a major funding problem in this country for a variety of reasons. So I wanted to go over the projects that we're doing on the front lines in Nevada. So those of you who are on the other end of this and studying the scientific basis can try to bridge that gap. So, as Ian said, we completed the first year of the R56. Well, was one of the sites there. We collected stool, saliva, plasma, PBMCs for the banking process, and also a great deal of data went along with that to match that set. We are in our sort of, well, I'm in my fourth, other sites are in their fifth year, I guess, with the CDC collaboration, using Open Medicine Institute as our centralized site. These new elements have been added as the science has improved, including NK cell function, standardized with a central processing. There's been a lot of debate about NK cell function and how it should be done and how the blood should be processed, et cetera. Exercise and cognition was completed. We've added the nasoline to the regimen. We recently finished a collaborative study with OMI on high-dose B12. I hope that somebody wants to pick up that data and analyze it and publish it for us. And the second-year follow-up of exercise and cognition. We have an R21 with Roxana Mosley at the State University of New York with 54 patients, sex-matched controls, and a first-degree relative. And as those of you who do any clinical trials know, the controls and the first-degree relative are the hardest part of this study to recruit. This is to identify secondary illness prevalence, particularly lymphoma, and autoimmune disease in these patients, because there does seem to be a trend toward autoimmunity and development of lymphoma, at least on our 30-year follow-up. And we collected serum and PAX genes for this, and the first part of this study is just collecting all the data, all the questionnaires, and the samples. We're part of Maureen Hanson's study in terms of the Seahorse Project to increase the numbers, and we're collecting larger amounts of blood, as she mentioned, so we can look specifically at the different immune parameters. And this was very interesting in view of rituximab and the fact that a certain group of patients respond to that drug clearly, but we don't know which one, and it's not a particularly benign drug, and it's also very expensive. So we collaborated with CellTrend in Germany and sent 70 sort of random specimens. And let's just look at the beta-2 adrenergic antibodies. 12% were positive, which is almost the identical number that she reported from Germany in 2 studies. And if you took patients who had multiple antibodies, it decreased in numbers, of course. But if you divided the people who had very positive antibodies, 8 of them had very severe POTS. And 3 of them were on IVIG, which just indicates to me that these antibodies are prevalent, at least in pooled serums, because gamma globulin is, of course, from a number of donors. So probably it wouldn't be a diagnostic marker necessarily, but certainly did call out these 8 patients with severe POTS. And we plan to extend that study as well. As part of this, we also did complete autoantibody panels, screening on an analyzer panel that gave us 39 autoantibodies. And you can see a number of these patients had other antibodies. So the role of autoimmunity may be very real and very actionable with respect to this subset of patients. I've been concerned about who's going to replace me, who's going to replace Nancy. The demand far exceeds the number of physicians specializing in this disease. I had a research fellowship funded by a very generous donor, and it took 3 years to recruit a fellow. I've now filled that position and look forward to fruitful outcome, perhaps. At least in California now, your chances of seeing a physician are very, very low when you go to the doctor. It's going to be a mid-level, a nurse practitioner, a PA. So I've changed my focus and have some funding to train mid-levels in the office, at least to do screening and to identify and probably diagnose. It's a harder curve in order to teach treatment modalities. We've started some cross-specialty educational workshops locally with the occupational therapists, the physical therapists, and things like that. And we have a pilot funding for young investigators for very small, innovative projects. And we've had a great deal of interest in this. It appears that the research community is much more open-minded than the practicing medical community. So future projects that I have in mind, of course, we've heard about this, and I'm very excited to be part of this collaborative effort. We want to try to study the T and B cell clonal rearrangements that's seen in a subset of patients. And the reason for that is that all of my patients that have developed lymphoma have first had a B cell or a T cell clonal rearrangement. And Mark Davis gave a very interesting talk at Stanford a couple months ago because he also recognized patients with this abnormality. He did a single cell sequencing on one of the patients and alleged that he knows what the antigen is in that patient. So I've collected 50 B cell and 450 T cells over all these years and have bone marrow, blood components, and lymph nodes on the vast majority of these people. So this is an example, I think, of where the technology has reached the point now where we can process some of those and learn a great deal. The idea would be, as those of you who recall the rituximab trials, they came accidentally on patients who developed lymphoma and were treated with rituximab for their lymphoma, and their chronic fatigue went away. So it's a very interesting subset. We have a study for HHV6 integration for our whole brains that have been frozen for a long time. And that's because HHV6 variant A integrates very close to the telomere of the cell and therefore may play a role in early aging and dementias and other things that we see in some of these patients. So in anticipation of what clinicians are going to do in a center of excellence, I designed this scheme about a year ago and put it into piloting for what a physician can do and how you can operate. I just wanted to share it so you get some idea of the front lines again. So this is currently what I'm doing with new patients. On Monday, they have a 2-hour consultation with a physician, their blood draws, the standard core elements, supportive intervention. Many of these patients require saline or rest or something just because these days are difficult for them. Day 2, we have a 1 or 2 day ETT, depending, and we do the same blood, not the same, all the same, but we do cytokines and store blood after the 2nd day. Wednesday, they have their diagnostic imaging, depending on what's necessary, MRI, SPECT scan, PET scan, or anything else that may be necessary. Thursday, the lumbar puncture, if it's indicated by neurological findings, or we have an algorithm for determining the patients where that may be useful. And then Friday, we have most of these results back these days. So I'm able to do a review of the initial visit and diagnostics and make some recommendation to their primary care doctor with respect to follow-up. And this has been very popular and somewhat successful. We have to sort of get some of the kinks out of this, however. And lastly, we have biobanking that we've had for 33 years. I think Ian taught me that way back then. Incidentally, I do have to comment because the patient he mentioned I remember very well, and she remembers him very well because she'd been at another very famous institution in California and been diagnosed with conversion reaction. And Dr. Lipkin said, I don't know what she has, but it's not a conversion reaction. So she's very happy about that. So we've accumulated about 400 aliquoted spinal fluid samples, bone marrows, PBMCs by the hundreds, serum, plasma, tissue biopsies, lymph nodes, spleens, kidneys, brains. And those have all been maintained at -80 and never thawed. So it's a very valuable source for collaborative research in the future. We also have 8,000 exercise tolerance tests with expired gas exchange that have been accumulated. And as far as big data goes, that's why I was so excited about perhaps being able to utilize some of that information. MRI, SPECT scan, cytokine profiles, NK cell function, et cetera. And now, most recently, we've superimposed the treatment dates on top of those laboratory values for things like Ampligen or antivirals or other symptomatic treatments, which should make it amenable to big data study. So thank you all.